Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist I have provided almost all the topics in a very systematic order and you can make use of it for the systematic study. Thank you very much. Hope you will make use of it. My dear friends, as we know, we were discussing about rickets. In the rickets, we have seen already the rickets due to vitamin D deficiency and its varieties. Then rickets due to calcium deficiency. And now today we will see rickets due to phosphate problems. Now, phosphate is very important factor in the formation of the rickets. One, I told that phosphate is very important for laying down the matrix, isn't it? The necrosis layer, proliferation and necrosis layer, where the cartilages are get destroyed or undergo programmed cell death, and later that cartilaginous area will be occupied by the phosphorus. Once the phosphorus come and accumulate, then the calcium deposition start, and this is how the mineralization begins in the growing end of the growth plate of the bone. Therefore, phosphate also plays a very important role in the manifestation of the pathology of the rickets. Now here, if the phosphate is more than the normal level, then also it is dangerous. If the phosphorus is less than the normal level, then also it is dangerous. If phosphate is more than the normal level, then it leads to hyperphosphatemic rickets. If the phosphate is less than the normal level, then it leads to hypophosphatemic rickets. Phosphatemia means less level of the phosphate in the blood. Now, how this is possible? Okay, so that we will see today. See, first we will discuss about hypophosphatemia rickets, where the phosphate level is less in the blood, and now this leads to rickets. In this regard, we will study three important disorders. One is X-linked hypophosphatemia rickets. Hypophosphatemia, that means amount of the phosphate is less in the blood. It may be because of one problem called as X-linked hypophosphatemia. Another is autosomal dominant hypophosphatemia rickets. The problem is with the dominant gene of the autosome. Similarly, third one is hereditary hypophosphatemic rickets with the hypercalciuria. Now, first we will see the X-linked hypophosphatemia rickets, how this happens. This is the most common form of refractory rickets. Refractory rickets in the sense there is no role of vitamin D supplementation. That means it is a refractory rickets. Vitamin D is already formed, but that active form of the vitamin D is not working now. This is the most common form of the refractory rickets, and this is an X-linked dominant problem. When I say X-linked dominant problem, it is occurring in both male and female both. So it is dominant. So there will be a gene called as PHEX gene, and if that's PHEX gene defect, the full form is a phosphate regulating gene on X chromosome. PHEX, phosphate regulating gene on X chromosome. So PHEX gene, there will be a defect. This defect leads to increased degradation of the phosphatonin. Now, because of this genetic defect in the X chromosome, this is a dominant gene, there is increased degradation of a substance called as phosphatonin. There are many phosphatonins are there. One of the phosphatonin is fibroblast growth factor 23. Especially fibroblast growth factor 23 will be produced and its degradation will be higher, increased degradation of this particular phosphatonin. So once this undergo degradation due to increased concentration of the phosphatonin, there will be impaired renal tubular absorption of the phosphate. Because of this particular phosphatonin, which is undergoing more degradation, its level increases, concentration increases, and this increased concentration in the urine leads to impaired renal tubular absorption of the phosphate. Okay, it impacts the absorption of the phosphate. Phosphate has to be absorbed from the urine when it is passing through the renal system, but because of this particular fibroblast growth factor 23, which is degraded in excess and present in the urine, so that will prevent the phosphorus from getting absorbed. So it also inhibits another important, very important enzyme called as a 1-alpha hydroxylase enzyme. This phosphatonin increased levels also inhibit the 1-alpha hydroxylase enzyme, which is a very important enzyme which convert the storage form of the vitamin D into active form. So it inhibits this enzyme. So level of the active form of the vitamin D is less. 1,2,5-DOH will be decreasing. So now overproduction of the phosphatonin will be also seen in certain mesenchyme tumors like oncogenesis rickets, neurofibroma, or epidermal nevus syndrome. Phosphatidine overdegradation or overproduction will be also seen in some other conditions apart from X-linked hypophosphatemia rickets like oncogenic rickets, neurofibroma, epidermal nevus syndrome, etc. McCune-Albright syndrome, another syndrome called as McCune-Albright syndrome. Also there will be increased level of the phosphatonin, and this also causes hypophosphatemic rickets. In a syndrome called as Albright syndrome, McCune-Albright syndrome, also you will find hypophosphatemic rickets. The reason is in that disease or in that syndrome also the level of the phosphatonins will be increased. Some other diseases like Dent disease, neurofibromatosis, Fanconi syndrome, also we will find a similar presentation. Now the thing is, there will be the absorption, absorption of the phosphate in the renal tubules will be impaired because of this increased amount of the fibroblast growth factor 23. And now when it is impaired, what happens? Now suppose if it is decreased, its absorption is decreased. That means impaired in the sense is the phosphate is getting lost more phosphate will be lost. But when the more phosphate will be lost, naturally there will be less phosphate in the blood, and that leads to hypophosphatemia. And once the hypophosphatemia is there, now calcium mineralization also get affected. We know that they are very good friends. If phosphate is more, it will bind extra amount of the calcium which is present in the blood and make it inactive. If it is less, it will going to create problem in the bone mineralization, because calcium will not get absorbed properly without phosphorus. So here, because of the phosphate deficiency, naturally it leads to calcium deficiency, and naturally it leads to rickets. This is how the X-linked hypophosphatemia rickets will be formed. So many members of the same family maybe get affected. This is because of dominant trait. If there are 4 or 6 kids, maybe 2 of them may be suffering, one male, one female, like that. Now, one more problem where we will have the phosphate related problem is renal tubular acidosis. Renal tubular acidosis can also present with the characteristic features of refractory rickets. Proximal and distal renal tubular acidosis are very important causes of refractory rickets. Question is how? The hyperchloremic metabolic acidosis and decreased serum phosphate level will be seen. Whenever you talk about renal tubular acidosis in PCT or DCT, actually there will be metabolic acidosis, isn't it? And also there is a decreased serum phosphate level. Serum phosphate level will be decreased because in the sense when acidosis occur, the phosphate absorption is also get impaired in the urine. It is more phosphate will be excreted. So, but the level of the serum creatinine and the blood urea is normal in RTA. This is how the renal tubular acidosis, various causes, renal tubular acidosis can occur because of various causes. In all such conditions, also there will be phosphate excretion, more phosphate excretion. That leads to hypophosphatemic rickets if the problem is persisting for a longer time. So one more important phosphate problem which we have to find is chronic kidney disease. Suppose there is chronic kidney disease. Now we are talking about hyperphosphatemic rickets. So far we are talking about hypophosphatemic rickets. Now let us discuss about hyperphosphatemic rickets. In chronic kidney disease, the patient will be presented with the hyperphosphatemic rickets or the renal osteodystrophy. It is also osteo related to bone. So it's also called as renal osteodystrophy. What actually happens in chronic kidney disease? When more phosphorus is there in the blood, it binds with the active calcium in the blood. So and make it unavailable for the mineralization of the bone. This we know. This is the only condition related to rickets where the level of the phosphate is increased in the blood. Which one is chronic kidney disease? In all the chronic kidney diseases, renal function will come down, shut down. So one of the renal function is absorption or reabsorption of the phosphorus. Okay, so that means excretion of the phosphorus. Excretion of the phosphorus is one of the important function of the kidney. Now that excretion is not taking place. Okay, so phosphate is get retained in the blood, and that phosphate will be increased in the blood, and that leads to hyperphosphatemic state. Okay, and that hyperphosphatemic state, when phosphate is more in the blood, it will go into bind with the free form of the calcium, make it unavailable for the bones. Okay, so this is the only condition related to the rickets where the level of the phosphate is increased in the blood as renal function itself is impaired and phosphate is not at all excreted, hence it is retained in the blood. So in this case, there will be also decrease the production of 1-alpha hydroxylase enzyme. Hence, just like in hypophosphatemic rickets, even in the hyperphosphatemic rickets also, ultimately in the next stage, it will also affect the production of the 1-alpha hydroxylase enzyme also. So vitamin D active form is decreased, and again it further add to the rickets. One more condition that we have to see is the fluorosis. Endemic fluorosis may also lead to rickets. The levels of the fluoride increased in the water in certain endemic areas. When consumed, it leads to fluorosis. In this condition, there will be erosion of the bony surfaces with the bony deformities will be there with a similar radiological finding to that of the rickets. Of course, this is a very rare condition. So in the next class, we will see some different other causes of the rickets. And basically in the next class we shall see the pathophysiology and as well as the clinical symptoms of a rickets. So far we have seen all the things: vitamin D related, okay, calcium related, phosphorus related, phosphate related, okay, even chronic kidney disease related, renal tubular necrosis related, like that. Different aspects we have already seen. Now let us systematically divide the things and we shall look into the clinical presentation of a rickets from the next class onwards. Thank you very much.